This meeting is being recorded.
So you might want to go to full screen. Brilliant. That's brilliant. Go for it. So Aska, we can't, we can't hear you. Is your audio enabled? Brilliant. Yeah, just unmute yourself.
Okay.
Yeah, brilliant. Go for it. Yeah.
Okay. So this is a preterm baby. He is a 36 weeker now, 26 weeker now, 29 weeker. His problem list is RDS. This is scan done yesterday. He is on conventional ventilation on ACBC mode with a maximum setting. We can see the chest X-ray with a little bit overdistended lungs. This scan done after yesterday evening gas a little bit worsening with pH of 7.1, CO2 retention 64, and bicarb of 19.4. Actually, the baby saturation was still stable, hemodynamically stable. So I've done this scan just to assess.
Brilliant. Brilliant.
So yeah, the machine we use is, I don't know how to pronounce the machine name.
It's a logic here.
Yeah.
Brilliant.
Frequency of 12, depth of 3, and use the hockey stick probe. The limitation that the baby was moving and with poor abilities.
Sure.
So yeah, this is R1.
Very nice.
Yeah.
Very nice.
I can see like 3 intercostal spaces.
Brilliant.
With the pleural sliding.
Yep.
I can see many A lines, and I think it's B lines also here.
Very good.
And here.
Very good. Yeah.
There is some comet tail here.
Brilliant.
It's not extending to the lower. With the rib shadow.
Yep.
Okay.
It's a lovely image. Can I just say you've got very good penetration? I mean, for your you've got lung all the way down. You've got a nice kind of batwing sign. Very nice kind of pleural margin. A little bit thick, the pleura, which is not unusual for a preterm baby.
Thick.
Yeah. And for
and
all
I think okay.
Yeah, sorry, for all of you, double lung point. I mean, just you've got an A profile in the middle with a B profile on either side. How old is the baby?
Now 3 weeks, almost 3 weeks. Born on 14th of March.
Brilliant.
But it's still in the ventilator.
Sure.
Okay. Yeah, this is R2. Also, like 4 intercostal spaces with bat signs, battering signs. There is a sliding, good sliding of the pleura with multiple A lines and few B lines here and here.
Yeah.
And very minimum comet signs also in the top.
Yeah.
Okay.
Brilliant.
This is R3.
Very nice image.
Yes. Yeah.
Very
it
nice
shows
image.
maybe 3 ribs and 4 intercostal spaces with rib shadow. There is a lot of A lines, and I think B lines here is less than the other.
So at the moment,
R1 or R2.
You're getting a lot of artifact in the bottom of the screen, and I think it's
actually,
because the baby is moving.
Yeah, he's moving, and this is. I record the videos. I couldn't
Sure.
download the videos from the machine. But
Sure.
later on, I learned how to do it.
Brilliant.
So,
Brilliant.
Actually, me and Dr. Buja were looking for any signs of pneumothorax, of loss of sliding, or that the lung with 2 sides, one is moving, one non-moving.
Yeah.
But I don't think there is. Okay, so let's move to the left side. Okay, this is the left side. This is L1. Also, the pleura is a little bit thick, but it's sliding with a lot of A lines and comet tails. But I don't know if the penetration is not very good here.
It's okay. It's good. I agree. This is kind of a recorded image, but for me,
Yeah,
you've got an kind of an A profile on the right, and you
yeah,
definitely have a B profile on the left. So again, a double
yeah,
lung point, very thick
yeah.
pleura, some comet tails. Well done. Yeah.
Okay. This is L2, a little
Mhm.
better image with 3, sometimes 4 ribs showing, with 3 intercostal spaces, with a lot
Mm.
of multiple A lines. I don't know, sometimes B lines appear, sometimes disappear. I don't know, is it an artifact from the videotaping or it's the true B lines?
Okay, so I want the audience to tell me what's happening. So B lines appear and disappear. What's happening?
Yes,
Anybody?
Alok.
Yeah,
Yes, yes.
go for
Hi,
it.
Alok.
Yeah.
You said the last lecture that with good inspiration of the baby, we see the airlines when the air comes in, and when it comes out, B becomes more evident.
Okay.
Okay.
Brilliant. So if I explain that when you inspire, your alveoli will expand, the lung will be aerated. Your interstitial
Yes.
spaces where you've got the trapped tetrahedrons, which give you the B profile, will get squeezed. So you will see less B lines and more aeration. And this
Mm.
is classically why we've invented the concept. I've invented this concept. Uh, Not a lot of people around the world kind of believe that we should have what we call as an AB profile, but I think it's really important that we do because you will in aeration have aeration of the alveoli. So having kind of a profile where you have A and B, A in inspiration with B that comes back because you have expiration and a kind of appearance of the B is what we call as an AB profile. And what it indicates is that there's an element of transition happening within the lung.
Yeah.
Carry on, Dr.
So
Weeb. Yeah.
this lung is still wet lung.
Yeah.
Yeah. So
No, no,
this
no,
is
no, no, not wet lung. I'm gonna cover that today, but yeah, I'll talk about what I
okay.
mean. Yeah, yeah,
Okay.
yeah.
So this is L3 with 3 ribs and bat wing signs. The pleura sliding is okay. Okay, a lot of A lines. And here also B lines appear and disappear.
Sure.
Okay, with good penetration in some part and a
Brilliant.
little bit poorer in the other part. I
Brilliant.
couldn't do any back scans. I was
Okay.
alone, so I couldn't tell the baby he is on ventilator, so I couldn't do it.
Okay.
Okay.
Completely understandable. So I'm gonna pick on two people. So who should I pick on? So I've got Leah. Leah, can you unmute yourself?
Okay. This is the X-ray before this bad gas.
Sure.
This is a morning X-ray.
Okay. So I've got Leah and I've got
Yeah.
Leva. Leva, can you unmute yourself? And can we get you on camera?
I can't go on a camera at the moment. Sorry,
No
I'm
problems. It's
I can
okay.
stop sharing.
That's
a very
fine. It's
limited.
okay. It's all right. No, no, don't stop sharing. We want to see.
Oh,
We're discussing this case. Yeah.
okay.
So you've got a history of a 3-week-old 29-weeker who's still on the ventilator, who has a rising CO2. Okay. And you've got this lung ultrasound appearance and kind of the chest X-ray appearance at this particular point.
You can see?
No, we can't.
Okay.
Yeah.
Okay.
So I'm just thinking, so we'll go to Leah first. What are your differentials?
For the ultrasound findings, or for the case in?
So for the case and lung ultrasound findings together, when you mentally model, I mean, you've got a baby whose CO2 has gone up. So what are you thinking? So just a broad set of differentials about what you think might be going on clinically.
Well, I suppose, yeah, you're kind of, is this an evolving chronic lung picture? Is the baby got developing sepsis? Could there be pneumothorax?
Brilliant.
Yeah.
Okay.
In terms of, I haven't, this is my first session of the actual ultrasound course. So
So
in
don't
terms of the
worry.
actual ultrasound findings, um, I have
It's
very limited
it's a
knowledge.
brilliant differential diagnosis. It's absolutely brilliant. Now, can I say why? So, Leva, do you want to add to that before we come in to the concept of mental modeling?
No, I was also thinking pneumothorax, mainly developing sepsis/pneumonia could also
Yeah.
be a reason.
Yeah.
Yeah, the baby's already 3 weeks old, so it's a different presentation than a freshly newborn.
Brilliant. So one of the things that, I commented on right at the start, the pleura is starting to look quite thickened. You've got A and B profiles side by side when you kind of look at the images. So you've got decent, well aerated lung associated with an element of interstitial fluid. Now, few things. Obviously, common being common, we want to make sure that there's no sepsis. It wouldn't be unusual in this situation if you didn't have an answer to screen start antibiotics. But you have no evidence of subpleural consolidations. You have pleural sliding throughout. So just following the kind of batwing sign, pleura ABCD approach, we look at the pleura first, it's thick. We don't have any subpleural consolidations below that to kind of support a lot of persisting respiratory distress syndrome, kind of evolving lung disease. We don't anteriorly have any atelectasis. The pleural line is established in all the images. It's sliding, so this can't be a pneumothorax. And when we look at the entire kind of right and left side, we don't even have any large lobar consolidations or atelectasis. So actually a kind of a mnemonic kind of a presentation or a tube down the right bronchus or a tube that's maybe stuck. We also have sliding over here in all the slides. So if you have sliding in all the slides, your tube with aerated lungs should be in the right place clinically. So it's not as if this baby's extubated. So, a classical example that I'm giving you on why are we mental modeling. In this situation, if you're doing the lung ultrasound and you suddenly see that you've got quite significant lung atelectasis with no sliding in a baby who's starting to desaturate, just ensure that you've not accidentally extubated. Also, few other things. So we kind of in this situation where you look at the baby. Now, sepsis with no kind of consolidations is a possibility. One of the other things, as your PVR drops, and if you have a PDA in a 29-weeker who's intubated, ventilated, you'll start seeing more interstitial fluid because of left to right shunting from the duct. So you have a B profile over here with some elements of aeration. And actually, the question is, this is one ultrasound, but if you did serial ultrasounds and this got worse with a loud murmur, I'd be thinking about whether the PDA is left to right shunting and I'd start doing an echo. So just few of those differentials. And then what you could have is evolving chronic lung disease. Now, the points against really bad chronic lung disease is you have well aerated lungs. So those are some of the kind of decisions you might make. And once you've kind of made those decisions, now in this situation, you might screen, you might start antibiotics. There's one big problem. What is the big problem here? Anybody? Anybody?
You mean to start antibiotic for a preterm?
No, my one worry is we have not done the posterior regions of the lung. And if this is a supine lung ultrasound, my experience of babies who remain ventilated for extended periods of time is that they often, if you're not proning them, they will develop lung atelectasis. You will just not recruit the posterior areas of the lung. Now, uh, there's a video that I'll share with you from one of our speakers, Almudinia, who basically spoke to us in the last kind of course. And what really is needed for babies like this, especially if they're chronically ventilated and they're not extubating, is trying to understand why not. I'm just wondering that you've got such good anterolateral lung aeration, of 29 weaker. Well, why is he not extubating? I'm really interested in finding out what the posterior regions of the lung show. Also, pneumonias. You can have solitary occult consolidation with fractal sign at the back. So a classical example is if I've done an anterolateral scan, I haven't found my answer. I would want to do an ultrasound of the back as well. I want to look for atelectasis, any fractal sign, and any focal signs that suggest that I've got a pneumonia. Now, when I present today, I'm going to talk about the PLAPS point. The PLAPS point is basically the posterior lateral part of the lung. It's the back. It's really what I would say is the kind of R5, R6, L5, L6 regions. An independent position, really exudate, all of those things will tend to kind of focalize in those regions. So just an awareness, where possible in situations like this, your first scan should always be comprehensive, which is anterior, lateral, and posterior. We know for the purposes of this course, that's not possible. So just scan anterolaterally and you'll learn as you go on. You'll become more confident of being able to scan through the posterior axillary line. And once you become more confident about doing that, it becomes much easier to do the posterior zones. Beautiful images, Dr. Weem, beautiful images. I have no, no kind of improvements that I can make. God bless you. Varun, are you in a position where you can share?
Yes, sir. Yeah, let me try.
Any questions? Any other differentials that would come to your mind? Anybody? For that
Actually,
case?
Dr. Alec, it's the same way we thought about this baby yesterday.
Yep.
Firstly, we thought about maybe sepsis, but he's screened recently and he's active with good saturation. His blood pressure is maintained.
Yep.
He's already on antibiotics. So, and with the ultrasound, there is no any consolidation area. So, less likely to be a worsening sepsis.
Yep.
And also, we thought maybe pneumothorax. That's why we've done this scan.
And he doesn't have a ductal
which
heart murmur? He doesn't have a ductal heart murmur at the moment.
no, not
Okay,
really.
brilliant.
But
Brilliant.
yeah. But actually, the nurse, she just gave us a comment that during the care there is a very sick secretion from the mouth and even from the ET tube. So
Yeah.
we just suggest to do open section and then to reassess the gas after a few hours.
Brilliant.
But regarding this back scan, I might do it tomorrow morning and show you.
God bless
Yes.
you. God bless
Yeah,
you.
I'll try.
If
Yeah,
we can,
thank you.
we can do it in the next peer review. It'll be very interesting to see. Yeah.
Yeah, I will do it early morning.
Sure,
I'll ask
sure.
someone else to tell the baby a little
Sure.
bit.
God bless you.
Yeah.
Thank you so much, Dr.
Okay,
Weem.
thank you so much. Thank you.
Go for it, Varun. Full screen.
It's full screen, sir, or it's not?
No, so if you just press full screen, right corner, yep, that's it.
All right. Uh,
Okay,
so this is the case history, sir. You can see this slide.
yeah, I can.
Yes, sir. So basically, this is the baby who is the term admitted in our NICU, and since day 4 of life. So currently, when I did the scan, this baby was 10-day old, and first 3 days this baby was with the mother rooming in, and since this sibling had an history of electrolyte disturbances, and so this baby was being monitored there, and when the baby developed hyperkalemia, baby was shifted to the NICU for further management. This baby was delivered by LSCS with a birth weight of 3.6 kg and normal transition, and did not require any respiratory support after birth. But on day 10, developed new onset tachypnea, mild distress, and need of HFNC with around 25 to 30% oxygen requirement.
Brilliant.
So obviously the team started the management with doing an X-ray and then starting antibiotics for this baby and sending a sepsis screen. So this is the sonography machine which I'm using. This is GE Vivid T8, and I use this hockey stick with the frequency of 9 to 18, but I did the scan with frequency of 12.
Brilliant.
Right. And there was no limitation. Baby was cooperative on HFNC.
Fantastic.
So sorry to have included one slide on every.
It's okay. It's all right. I have no problems. Carry on.
Right. So this is basically R1.
Very
So
nice.
I made sure that there is a depth of 4 centimeter.
Yep.
And I can see the intercostal spaces 2 to 3.
Yep.
And then there is a pleural line.
Yep.
And I can see the sliding also.
Yep.
And this more towards, I can see few A lines and few, I think, this comets are visible.
Yep, you definitely have at least one B line in the middle coming through, and just on your left-hand side, in inspiration, it becomes an A profile. So, and you have a few B lines. But yeah, I wouldn't quite call them compact B lines at this stage. For me, this is a dominant A profile, aerated lung. Carry on. Brilliant.
So this is R2.
Brilliant. Yeah.
Right. So this is, I think, again, the sliding can be seen, and lot of A lines in this image.
Yep. Bamboo sign. It's brilliant. It's a beautiful image. Nothing to comment on. It's beautiful. So just pleura ABCD protocol. I can see very nice skin subcutaneous tissue. I can see pleura. So just when you compare with the previous scan and a baby with evolving chronic lung disease, can you see how sharp and thin the pleural line is? 0.5 millimeters at most, whereas the pleura there is quite thick, quite it's not discontinuous, but this is how you differentiate evolving chronic lung disease from lung pleura that's relatively healthy. Yep, carry on.
Right. Then this is R3. So done in the upper axilla actually.
Beautiful.
So I think similar finding A profile.
Yep, agree completely.
And then this is R4.
Brilliant.
So I cannot see any liver shadow coming here, but I think this is again A profile
Yep.
with some in between 1 or 2 B lines per intercostal space.
Yeah. I mean, I could probably just see one B line in the middle with the eye of faith, maybe one on the right hand side. So, yep,
Right.
less than less than three B lines per intercostal space is A profile. Yeah.
So this is L1.
So beautiful. Yeah.
Right. So this was like uh, I think
I'll,
even the pleural sliding can be seen, intercostal ribs and shadow is there with A profile.
yep.
In L2, I think because of the lung shadow, there was images was not good. Sorry, not lung, the heart shadow, maybe the heart lung pulse is there something.
Yep. So just a comment. So at the moment, two things. You're getting a very fuzzy image with a
Right.
dominant B profile with no A lines. A, you're not perpendicular. So just pleura ABCD protocol, I can see two ribs. So I'm just going to mark it. So I can see a rib here, a rib appearing here, one intercostal
Right.
space. It's a challenge because you've got the heart coming in over here. And because you're not perpendicular, you're getting, you can see these kind of broken A lines coming in with a dominant B profile. I mean, it's interpretable. So well done. It's never easy with the heart. As you move more laterally, my advice is if the heart is coming, Varun, just look at me. So if you find that you're doing L2 and this is the heart, then really what you want to do is try to come to the anterior axillary line and try and image the L1, L2 regions through that so that the heart doesn't come in there. Well done.
Right.
Yeah.
This is L3.
J.
So again, I can see the battering sign, the pleura sliding, and A profile. So no concerns here. And then this L4 also, there was no concern. 2 to 3 intercostal space, A profile, and I can see the pleura also moving.
Yep.
So now this is R5 where I think the pathology was detected. So here I can see again the battering sign is there. Pleura is sliding, but this is like a proper B profile.
Yep, absolutely.
Right, and this is more towards like a compact B line, sir.
These are compact B lines. So what I call them rectangles. So you kind of when you look at them, they're rectangular. So the
Right.
so very nice. There's just one thing, Varun. Anything else on this?
Yes, I will go to R6.
No. What about an R5? Just keep it on R5 and play R5. Anything else?
In background, there are some A lines I can see. It appears and then disappears.
Okay. So I'm just want everybody to focus on this region here. So can you see in inspiration, play it again? It 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 actually you don't get a pleural establishment here, and
Right.
the you've got a B profile underneath. This is basically consolidation with a little bit of atelectasis. So you have consolidation posteriorly. That would be a worry. So again, you're moving from completely aerated anterolateral lung to an acute B profile at the back in a baby who's 10 days old, who's got respiratory distress with the presence of a consolidation. Okay. Small consolidation, focal but small. Yeah, carry on. I'm just going to use my rubber to rub things out and then you can move to the next
Yes.
slide.
So in R6, I think what you were mentioning, the image which was there.
Yes.
So now here we can see more of pleural line disappearing and then tissue-like appearance coming over here and suggestive of this can be called as C profile.
Very good. This is a C profile. So you've basically got on the left side, you've got what we call is an AB profile. You've got kind of an A profile just coming in here in inspiration, dominant B profiles here. Now, basically, this is so important. This is a large area of consolidation with atelectasis. You've got these static air bronchograms coming in. The pleural line is falling away, and this is a B profile underneath it. So you've got that. Let's finish the scan. Never make differentials without finishing. Have you done L5 and L6?
Yes, so L5 and L6 is like typically good. Similar. So left lung is quite healthy, it means, like, because we could
So
not detect
beautiful.
any consolidation in the left side, any no B profile, always A profile.
Okay. And L6?
L6 is also looks okay with some spleen coming over here.
Yeah. Okay. So I'm going to stop you there, Varun.
Yes.
I'm going to pick on somebody else. Uh, Sailesh and Wafa, can you unmute yourselves?
Yes, sir.
So you've got a 10-day-old baby, sudden onset respiratory distress, anterolateral regions of the lung well aerated, left region well aerated, R region focal area of dominant B profile with a C profile, consolidation profile, uh, with some atelectasis. So what are you thinking? Differentials.
Sorry, I'm driving, Dr. Alok. I'm going to the duty.
Sorry, it's okay. Carry on, Wafa. I will pick on Sailesh. You carry on. Okay, Sailesh, go for it. Yeah.
So this could be one pneumonia infection, sepsis,
Brilliant.
and secondly, it could be just mechanical, like some atelectasis.
So why would what's the gestation, Varun?
Term baby, sir.
Yeah.
39
Full-term
weeks.
baby.
Why would a term baby develop mechanical obstruction if he's not ventilated? What could happen?
Yeah, first of all, I didn't understand why this baby is in the ICU. Secondly, there could be some secretions which could be blocking the bronchioles, which may cause this.
Brilliant, brilliant. So you're coming there. So even term babies can have microaspirations. They can aspirate while feeding. So again, your differentials are absolutely right. If you have such a focal consolidation with atelectasis in this region, and just remember, one of the hallmarks of pneumonia, you can have pneumonia with atelectasis, and when you get a lot of B profile adjacent, which is quite focal, that is basically lung edema. That could be inflammatory edema secondary to a pneumonia. So again, I'm mental modeling here. I'm thinking of the baby, and I'm thinking about my differentials. If this baby was tubed and ventilated, I'd be thinking about where my tube is. Has my tube gone down and migrated? Is this a supine baby where there's atelectasis secondary to a mechanical collapse? Points against a pure diagnosis of pneumonia. I don't have any fractal sign or broken down areas of pleura, and I have static air bronchograms, which tend to favor a kind of an atelectasis, but you can never exclude it. Any other differentials, anybody? So there's a condition which we call solitary occult lung atelectasis, which is seen focally and is well described by kind of our Chinese colleagues. But I think here, yeah, you've shown on the X-ray. I mean, this for me would probably fit with the possibility of either an aspiration pneumonia or pneumonia. Yeah. What was your CRP? Bloods I'm very interested in.
The first CRP was 16.
Yeah.
Blood culture is awaited. Initially, 24 hours is negative.
Sure.
Baby is doing otherwise good, still on 25% oxygen and HFNC.
Yeah.
And as Dr. Sherry was asking regarding the need, this baby is like having a resistant hyperkalemia because of pseudo-hypoaldosteronism. So aldosterone is very high, around 1500. So all this medical management of kind of hyperkalemia is going on with some sodium supplementation also.
Sure, sure.
So we started
Okay.
antibiotics and
Yeah.
right.
Brilliant. Brilliant images, Varun. No critique. Just keep doing what you're doing. These are
Thank you,
beautiful
sir.
images. Your machine is very nice. God bless you.
Dr. Alok, you have a comment?
Please, please, sir. Please come in, Dr. Ashraf. Yeah.
Please, can you show me the last scan اللي هو الار 6 اللي هو الار 6 last scan اللي هو فيه this
Yes,
one
sir.
here.
Yes, sir.
Two things you can do better. يعني just increase الجين little bit to be good for you. And once it like this area, the consolidation, make it horizontal scan. It will be delineated this area, make it bigger. You see the bronchogram is dynamic or static. It will be better view.
So,
Yes.
yeah, that's brilliant advice. So, what Dr. Ashraf is saying that if you want to see the consolidation, you want to magnify that image. So, you could take a further image because with dynamic and static air bronchograms, you might want to focus on that area. One process is you could just decrease your depth to just to focus on that area. My only other comment, and I didn't want to cover it because we've not taught you pneumonia, you need to put Doppler on it. It's very important. So just remember, everybody who's watching, that if you have a pneumonia or an atelectasis, this area here, now there's no lung tissue here and there's no aeration and the lung has collapsed. So actually, you'll find vessels up till here. You won't find a lot of vessels within the region. But when you have a mnemonic consolidation, you get a lot of inflammatory edema and exudate, and you get what we call as reperfusion of those areas. It becomes very vascular. So if you see increased vessels in that area, that again favors a diagnosis of consolidation, possibly pneumonia. So well done, Dr. Varun. God bless you. I'm
Sir, any
so
role of M mode because I didn't do an M mode over here.
no, you M mode will give you a seashore sign everywhere. You should ideally you should do it, but I think I can confidently see sliding everywhere, and I just recognize, handling a baby and doing an M mode in every region can be quite a lot. So God bless you. Well done.
Thank you, sir.
Thank you, Dr. Ashraf. God bless
I
you.
have two queries.
Yeah, sure.
So very interesting case. Thank you, Dr. Varun. About this atelectasis versus pneumonia. So when in case of atelectasis, we can also get a CRP reaction, right?
Yeah, pneumonia can cause atelectasis if you have exudate basically blocking the terminal bronchiolar kind of space with the alveoli. Then naturally you won't get aeration. So pneumonia can be associated with atelectasis. So in
And then
itself, yeah, atelectasis is just, it is a kind of a presentation of the lung. It could be mechanical, it could be mnemonic, it could be because you have compressive atelectasis from pleural fluid outside. So, yeah.
And then when we repeat the scan after a couple of days, we can see a resolution in atelectasis, but in pneumonia, it may be still abnormal changes.
So if it is mechanical collapse, and we won't cover that today, there's a certain S pattern. Maria, who's on our course, has done a lot of research on that. And there is also what we call as linear bronchograms, air bronchograms that are linear. If you have that pattern, you can recruit lung. And what I would say is that, look, if it's tube down the right main bronchus, you pull the tube back. You can repeat an ultrasound within 60 minutes after pulling the tube back, and you'll start seeing aeration. A pneumonia in itself, just remember, pure pneumonias, less than 11% of tissue in studies is recruitable. And be very careful, because if you decide that you want to improve a baby's condition, by trying to increase pressure, you might not recruit a pneumonia. But my bigger worry in those situations is what happens to the non-distended kind of normal lung is it gets distended and damaged. And that is why you have to be very careful with how you do recruitment maneuvers whilst trying to differentiate consolidation, atelectasis, and mnemonic kind of clinical presentation. But with pneumonia, you can do postural drainage. And we'll look at a case, a very nice case, when we do pneumonia, which gives you the benefits of understanding that you don't always have to increase lung pressure to recruit mnemonic consolidation. Postural drainage in physiotherapy helps. It helps postural drainage and that helps recruit lung. So the fact that you don't have S lines, you don't have kind of linear air bronchograms, doesn't mean that you can't open that area of the lung up. Does that make sense?
Yes, sir. One more query. When you say pleura ABCD,
Yeah.
So I guess the ABC is the lines, and what is D standing
Okay.
for?
Brilliant. Okay. So what we're saying is whenever you look at any scan, you look at the batwing sign, you then discuss the pleura, you look at its continuity, integrity, what it looks like in terms of its kind of thickness, whether it's sliding or not. A, B, and C stand for the concept of A, B profile, C profiles, and consolidation. And D basically is making sure that you're looking for any kind of effusion. So really D and E cover that aspect of it. The most important thing from our perspective is it's a descriptive kind of a thing. I'm just trying to see if I can find a slideshow. I'll open it up so that you can have a look at it. But I've shared the article with you. I want you to use this to describe and report. It's very important because it means that you've structurally, like you do sequential segmental analysis in a echocardiogram. This is the kind of sequential segmental analysis that you have to do for a lung ultrasound report. Okay.
Alok,
please.
may I
Yeah.
ask for something?
Yes, please.
Alok, could you please just at any one of our lectures to show us how precisely we can detect pleural effusion? Because for me, it's a little bit difficult.
There's a whole session on it. There's a
Okay,
whole session.
okay,
Yeah,
thank
yeah.
you. That's
So
perfect.
so have a look at your program, guys. We will cover everything. So we will be
Okay.
starting with RDS, pneumothorax. We'll then be covering consolidation atelectasis, then pneumonia, then pleural effusion. We'll talk a lot about how you do insert chest drains for pleural effusion, how you use lung ultrasound to do it. It's all covered. It'll all be covered.
Thank you.
Okay, we're gonna move on. So Aska, are you able to share?
Yeah, doctor.
Very nice cases today.
Can you guys see my screen yet?
No. Yeah, now we can see. Brilliant. We can go to full screen. So if we just go to full screen mode, yeah, brilliant. You using a
All
Mac?
right, so
A
yeah,
Mac?
now you can see it?
Yeah, we can see. Are you using a Mac?
No, I'm using HP.
Okay, brilliant. God bless you.
So good evening, everyone, all of my friends online. My name is Aska, and I'm a neonatal fellow in Dubai. So my case is that of a 31-weeker who is almost 1,500 grams female baby. When I did the scan, this baby was almost 68 hours of life, was born to a book mother who had received 1 dose of betamethasone. And regarding her reports, only a thing which we could find positive was the HVS culture positive for Candida. And she was taken for an emergency section because of antepartum hemorrhage. There was placental abruption. So when the baby was born, after the initial steps required PPV, followed by CPAP in the delivery room, and was brought to our NICU on non-invasive ventilation. The ABGARs were 7 and 8. Upon examination, of course, the baby had subcostal recessions. There was some element of grunting as well. On the initial settings, on RAM IMV, the FIT requirement was 70%, was kept on settings of 26/6, I time of 0.5, rate was 40. And just to mention that this baby required overall 3 doses of surfactant. So upon admission, because in view of the severe respiratory distress signs and the FIT requirement was 70%, we gave first dose upon admission through LISA. And after which the FIT requirements came down, the clinical condition was better for a while. But then again, in 12 to 14 hours, the FIT requirements went up to 40%. And the SATs were borderline. So we went ahead and gave second dose of LISA to the baby. Then, on a duration of almost 30 or 36 hours of life, this baby again had borderline SATs, had signs of respiratory distress. And we did a lung ultrasound at that point in time, which showed a BRAT score of 11. There were also saturation fluctuations and chest X-ray, which I'll show now. So at that point in time, we decided to...
Sorry,
Sorry,
Askaji, your gestation at birth, I missed that, was?
This was a 31-weeker, doctor.
Okay, thank you, Ji.
Yeah. So we decided to keep the baby intubated, and we gave the third dose via ETT. And then this baby stayed on conventional ventilation for 2 days. And when I did the lung ultrasound, this was actually after extubation of the baby. So coming on to the x-rays, the one on the left-hand side was the first x-ray upon admission. And the second x-ray is actually pre-extubation and the pre-lung ultrasound, which I'll be showing the images now. I don't have an ultrasound, which we did after or at the time of lung ultrasound, because baby was actually doing clinically well at that point in time.
No problems.
So my lung ultrasound, I used a GE machine, used a frequency of 12, gain, correct me if I'm wrong, it was reading 38 at that time. I used a hockey stick, and limitations was that it was one of my first few scans, and that baby was on non-invasive support. So of course was moving around, even though my staff nurse who was there on duty, she was really kind enough, and we tried stabilizing the baby. Now, this is my right side. This is R1.
Brilliant. Very nice.
So I can see lung sliding, I can see A lines, and over here I can see like 2 B lines going all the way down, and I can see some comet tails over here. Doctor, correct me if I'm wrong.
No, absolutely right. Absolutely right. Very nice image. Very nice image. I can see airlines all the way down in inspiration. You could use a slightly lower frequency.
Yeah.
So if you're able to, because he's a 31 weeker, what's his weight?
His weight is 1500 grams, doctor.
Yeah, so you could kind of drop the frequency to 10 and see whether you get slightly better images in the deeper part, but it's a lovely image, perfectly interpretable. It's just you're losing out on this area of the lung. So, but yeah,
Sure.
for me, it's well aerated. Brilliant.
Sure.
Carry on. Yeah.
We'll keep that in mind. And I've just kept, to create a mental model, I've kept like the BRAT scoring in my mind, where we look at the anterior and the lateral areas. So I would give this area a score of 0, doctor, if you agree with me, because I can see A lines and I can see B lines, which are like less than 3.
Bahut khoob. Absolutely.
Yeah.
Ji.
Okay. And then the second one is in the R2 region. Unfortunately, this video is not playing for some reason, but there was good lung sliding over here. And I can see that are we going to call this subpleural consolidation, or are we going to call this thickening?
That's a beautiful question. So, guys, I want you to focus on this very carefully. It's a very nice example of how pleura may appear thickened if your probe is not entirely perpendicular. So, can you see how when your probe is in good contact and perpendicular, your pleura is nice, thin, and crisp? So, this is not a baby who's got any element of chronicity of the pleura at the moment of chronic lung disease. The reason why it's appearing, it's a little bit blurred and thick here. So all you'll need to do, and your baby is moving classically, is just adjusting it so that the probe is held perpendicular, and you'll find that you'll get a crisp pleura. There's no reason why, in this you would have such an acute difference between the two regions. If the pleura was thick, it would usually be thick in its entirety unless you had focal consolidation. Again, my only other comment is that if you're not perpendicular, there's just a risk you'll miss out on aeration and A profile. So, but yeah, it's the limitations, and I'm going to show you scans today where I've struggled. So well done. Very good. Very good. It's your first scan. Brilliant.
Thank you, doctor.
God bless you.
Then moving on to the lateral side, I can see again lung sliding. I can see A lines, some of the A lines, and I can see more than 3 actually B lines over here.
J. Yep.
The image moving. So I would give it a score of 1.
Yep. Brilliant.
Then I have taken some images from the back. So while the baby was positioned facing towards the left side, I know that it is excluded from the BRAT score, but just for the sake of understanding. So baby was moving a bit while we were taking from the back side. So I can see A lines, I can see some comet tails, and more than 3 separated B lines.
Yep.
And then this is the right lower back. Again, I can see confluent B lines in this area.
Yep.
Then on the left side, anteriorly, I can see pleural sliding, and I can see A lines. I can also see more than three separated B lines. So a score of 1.
Yep.
And then again, this area had some issue with the video, technical issue. So I could see A lines in this area. There was good pleural sliding, some comet tails. Again, but I wanted to ask, because it's showing a mixed picture, if I see this in a baby, am I going to score it 1 or 2? Because I see like over here, I was seeing more than 3 separated B lines, but if I comment on this area, it was sort of like confluent B lines.
So what I'd say is that in this situation,
Yeah.
it's a beautiful question again. You've got a kind of a B profile coming in here with an A profile coming in here. Classically,
Yeah.
you've got lung sparing. So this is a baby who's, with the clinical history you're giving me, and having looked at this, and ideally I would like to see the posterior regions. I just feel that the right lung at the moment is better aerated with a better A profile with very little kind of, I would say, B-line profile. I think even if you did R2,
Yeah.
again, with a perpendicular probe, you'd probably see better aeration with a crisp pleura. Now, I
Mm.
am a little bit concerned about the left side
Yeah.
because you are perpendicular here,
Yeah.
and your pleura here is starting to look thick. Even
Yeah.
here, compared when I look at the left
Yes.
anterior lower, I just think the pleura on the left side is just starting to look a little bit thick. This is definitely what I would say is a kind of a dominant B profile. Very few A lines that are visible. And then you've
Yeah.
got an AB profile. Now, how do you interpret scoring? In inspiration, if you see a full A profile and this B profile disappears, then technically you score it a 0.
Okay.
Okay. For me, at the moment, it would score a 1 because
Right.
you have a B with some aeration. I
Mm.
wouldn't feel confident enough to score it a 2. I can't see any subpleural consolidations at all. So it would
Right.
score a 1, especially if you have the persistence of the B profile. So definitely, I think, looking at it, I am a little bit more worried that, sometimes in situations like this, it's as much as we try, even if the right lung always gets a little bit more surfactant than the left lung because of the
Mm.
right main bronchus being a little bit more, in line. The left main bronchus
Yeah.
is a little bit more horizontal. Uh, and in situations like this, what you might find is that the right lung basically recovers a little bit more. The left lung tends to kind of have a little bit more of persisting RDS. The fact that you have no subpleural consolidations and a pure B profile is very reassuring because
Mm.
you don't still have established RDS. There is some chronicity of the pleura. So there is an element of, kind of the word I would use, and this is again a concept that we've spoken at length about in our kind of point of care ultrasound committee. We well know that chronic changes in the lungs start developing much earlier than 28 days for a definition of BPD. And you can see them as early as the first week of life. And really, what we need to be able to do is we need to be able to now define what is evolving lung disease in the context of the clinical profile of the baby. There's acute
Yeah.
RDS where you have subpleural consolidations and atelectasis. And then there is evolving phase. An evolving phase, if you start seeing double lung points with improving aeration, and that's getting better, then that's a baby that's getting better. It's very
Yeah.
nice images, beautiful. I mean, for your first scan, I mean, I
Thank you, doctor.
I would not have done that well. I know I didn't do that well. I was rubbish. So well done. Carry on.
Then this is from the left lateral side, and from the back, I could only get one image. So on the lateral side, I can see pleural sliding and I can see confluent B lines over here.
Yep.
And then one image from the back.
Yep.
Where again, I can see confluent B lines.
Yep. Left lung is definitely worse. And
Yeah.
you've got classical, if we just go back to that image, I mean, you've got complete B profile at the back. Uh,
Yeah.
so, I mean, and here what's happening is the pleura, you're starting to develop atelectasis, and it's classical. I mean, supine babies, they tend to recruit and worse at the back than anywhere else. Sorry, I'm
Yeah.
trying to rub it out, but yeah. So, especially on this left lower back, you can still see pleura here that's established, but you're actually
Yeah.
seeing pleural breakage over here. Now, just remember, these aren't subpleural consolidations. This is lung atelectasis. So you've got B profile with interstitial edema, and then you're developing consolidations with lung atelectasis. The pleura is breaking down over here. So again, your baby's extubated over here?
Yes.
Yeah.
This lung ultrasound is post-extubation, doctor.
Proning him would really help. You can recruit the posterior regions of that left lung by proning him. And the advantage with proning him is you may not have to increase pressure. So if you increase pressure, your right lung will be more well recruited as compared to your left lung. So actually proning without increasing pressure will help you recruit the backs much better. So
right.
Okay. Great.
And that's all, doctor. My diagnosis is RDS, and I would give a BRAT score of around 8 for this baby.
Sure. So Aska's using BRAT score to kind of follow this baby up. It's a little bit late to kind of think about RDS. The word that I would like us to use as a group is evolving lung disease in the context of prematurity. So it's evolving. Now, if this progresses to more aerated lung, you start seeing more A versus B profiles like you can see on the right side. You repeat the scan, and if you can, Aska, we'd love to see what this X-ray looks like in a week. So we'll do the BRAT score, and we'll look at the left lung in 1 week, and let's see where we are.
Doctor. We'll do that. Thank you so much, doctor.
God bless you. Thank you.
Thank you.
So, Hiba, go for it.
May I ask just a query about the BRAT score?
Yes, sir.
Do we have to include all the areas while scoring?
No, you do BRAT score by definition, and is anterolateral, R1, R2, and then one lateral region. Now, just remember, the lateral regions also divide into R3 and R4, and people get confused. If R3 is worse than R4, what do I do? Basically, you're looking at one confluent region laterally, and you're looking at the dominant profile in that region. If you've got the extended view like we have in our unit and we can see it, then you're basically looking at the dominant profile. But if it's a very big baby and you're having to look at R3 and R4 separately, just remember, score based on the worst profile. So if R4 has atelectasis, and you're scoring 3. So just remember, it's antero and lateral region score. You R1, R2, and then one lateral view. And then you have a lot of other scores. This Fernandez score. I know that Mahmood, one of my colleagues in Scotland, likes to use the all 3 regions score. A meta-analysis that's just kind of been done in 2023 shows that when you actually look at the diagnosis of respiratory distress syndrome and lung ultrasound scoring, using the posterior regions to score the lungs does not give you any additional advantages in treatment or treatment benefit as opposed to just using the anterolateral regions of the lung. And if a baby is prone, when you do BRAT score, then you do BRAT score from the back. So then what you'll do is you'll do R5, R6 and one lateral region, L5, L6 and one lateral region. You don't turn the baby around and do the anterior regions. So if he's prone, you can use the backs. Okay? Go for it, Dr. Hiba.
Okay. So my baby is 3 hours old during the time of examination, born at 35 plus 6. Mother was booked, but she wasn't following, and we think she might have had gestational diabetes, but no way to confirm. She presented immediately to the emergency department, was taken for emergency LSCS for fetal distress, was found to have increased work of breathing, but required non-invasive ventilation via CPAP. During examination, baby was still on CPAP. Did not require any Cervanta, but was started on antibiotics. So my scanner was Vivid IQ, frequency is 12, and used a hockey stick. And the baby was not very happy during examination, so I've limited my imaging to the anterior regions of the chest bilaterally. And here we go.
Brilliant, baby.
Thank you, doctor. So R1, we can see here the Batman sign with the 3 intercostal spaces. There is a mirror image underneath each rib, and there's no very clear overcast shadow from the rib itself. The pleura looks thickened, and maybe it looks a little bit fractured from this end.
What's your gestation for the baby?
This was a 35+6.
Okay. Yep.
And there are A lines, so it looks like a predominantly A profile.
I would agree.
There are multiple comet signs, but there are no significant B lines over here.
Brilliant. Lovely image, good penetration, good depth all the way through. You've got the pleural line, lovely sliding. I do agree the pleura is a little bit thick. Just remember in a bigger baby, a pleura up to 1 millimeter is acceptable. But even for that, I think it's just a wee bit on the thick side. So yeah. But in terms of kind of how it might impact diagnosis, I'll wait to see your remaining images. Yeah.
Got it. Okay. Then coming to R2, again, over here we have 2.5 intercostal spaces with batwing sign, and there's no significant overshadow from the rib, but there are mirroring present with a clear sliding noticed.
G.
Yeah, and then over here, I don't know what would you think about this region,
Okay.
Dr.
Yeah. So what I'd say is that when you are putting your probe down, you're using a hockey stick. So you're losing a little bit of contact in that region. So the fact that it's duplicated in both R1 and R2 and the rest of the pleura looks nice, uniform and linear, it's just loss of contact. Nothing to worry about. In this situation, sometimes what you have to do is you just have to basically reorient your probe. For me, there's no discontinuity. This is just a loss of contact. The image is fine. It's absolutely fine. And I would say looking at the pleura and now having seen your second image, I think it's just artifact because of the loss of contact on that region. So what it basically means is that when you apply your probe in that region, the hockey stick is at the top. Now just remember, the hockey stick, it's got a flat surface, but it curves off at the end a little bit. So when it curves off of the end, you have a little bit of lift over there. Hence, you just, that's more artifact than actually delineation. Nothing to worry about. The image is beautiful. Good sliding. Yeah.
Thank you. Now, okay, moving to my last two images on the left side. So my L1, over here we can see 3 ribs, a clear batwing sign, and intercostal spaces that are 2.5. And over here we can see a slightly thickened pleura still. There are predominantly there is siding. Speaking about the pleura, there are multiple comet tails, and on this side you can see like
A B profile.
yeah,
Brilliant.
please.
Yeah. I think what you're saying is they're coalescing on that side at the bottom. Yeah. So I just wonder whether you have a little bit more of a B profile to the right of the image. So if I just highlight it over here. So, and that is the slight disadvantage of using the hockey stick. If you had a linear probe, then a linear probe would give you a footprint to be able to see L1 and L2 together. So you'd be able to see the interface between these two. And I think what you'd find is maybe a zone of transition. It's okay. It doesn't make a difference because actually, even with this, you've got a very nice image on L2. Tell us about L2. Yeah.
So now coming to L2, so L2, I think I'm not very perpendicular over here, judging by the ribs that are slanting down. And I have one question for you, Dr. Alok. Why are the ribs here different? Like, like here I can see them like, radio opaque, while they're like, radiolucent.
So I'll explain. So if this is the baby's chest, okay, this is the right and left side. If you arrange your hockey stick like this, and it is completely linear, then you will get this kind of a shadow. But sometimes what happens is the hockey stick goes like this. It's slightly tilted. So you're in contact with the chest, but rather than cutting the ribs at a right angle, you're cutting the ribs obliquely. So if you're cutting the ribs obliquely, you may kind of get a slightly oblique view. You are getting rib shadow. This is a good image. There's nothing wrong with it. It's just because your hockey stick is a little bit oblique. But what you're getting is the benefit of still being able to see pleura. And you see a few comet tails with a very well aerated bamboo well sign. So nothing to worry about. Lung ultrasound is not about perfection. I'm going to show you images that are not perfect. Some of them are not even as good as the images that you've shown me today. The question is, can we make a reasonable interpretation after clinical correlation? These images are beautiful. You've got well aerated lung. What are you thinking about?
Okay, so I used your so I tried to use this report over here.
Yeah.
And I think it's a predominantly A profile lung. So it looks like a baby who might have had TTN and is recovered, but I can't tell for sure because I didn't scan the lateral and posterior areas.
Yeah.
But on the anterior aspect, it looks well aerated.
Yeah. And you followed the baby up and he got better?
I went on leave, so
No problems. It's okay. It's all right. I think with the images that you've got, yes, that's the diagnosis that I would be making. And if all I'd say is that if you do a limited AL profile, anterolateral profile. So as I said, there are three types of scans. There is what we call is the anterolateral scan. There is the comprehensive, which includes anterior, lateral, and posterior regions. And the enhanced basically is when you start doing each of the intercostal spaces as well with that. So all I'd say is that if you end up doing an anterolateral and your baby is not getting better, then complete the scan. Where possible, I would, as we progress, encourage you to try and scan the posterior regions through the posterior axillary line. I'll be sending a video of how we do it. And hopefully in your second month, we can try doing that. But if not, anterolateral scanning. And then if your baby is not getting better, revise with a scan that definitely looks at the posterior regions. But just in terms of your image quality, the penetration depth, gain settings, the beautiful images.
Thank you. I have a question.
Yes.
Because with the machine that I'm using at the moment, it's mainly touch screen. And I'm struggling to find where to adjust the frequency from. So if it's okay, Doctor, I'll send you a picture of my machine if you happen to know how to.
My thoughts are, Hiba, the best thing to do is let's arrange a bottom call. So just when you go to your machine in a quiet moment, switch it on, and we can arrange for us to have a look at it over bottom. That is the easiest way for me to look at it. Some of you are sending me still images of the machine, and the problem with it is I can't identify which buttons they are for the frequency. So my advice is we can use bottom map. I'm going to do it with a few people next week. So at a quiet moment, just you can arrange a time where we can just look through your machine and then just advise you.
Sounds good. Thank you so much.
Okay. We're gonna stop peer review for today. So for those of you who missed out, I know Amani is keen to present, and I think Anna, not Lopez, Anna Barboza will present. Is there anybody else who wanted to do peer review today who is not able to do it?
It's okay. I had a peer review today, but I can do it the next time if time doesn't permit. No
Sure.
problem.
God bless you, Dr. Shireen. I'm so grateful. So Shireen, Anna Barboza, and Dr. Mani will go first next time. And again, for those of you who want to do peer review, one-on-one, just over Zoom, as I said, from 3 weeks from the 12th, we will always have Thursday and Sunday sessions now. And just remember, now our expert speaker sessions start with Dr. Ashraf and Abhijit to start off with. So they're not to be missed. I mean, the the kind of talks that you're going to get are from the real masters of lung ultrasound. They're people who do research in lung ultrasound, but don't do much clinical kind of work. I respect them. I know they're very busy, and they're the people who've taught us. I've been in my nappies and I've been taught by people. Uh, and then there are people who do lung ultrasound day in and day out. And Dr. Ashraf and Abhijit are two of such my colleagues. Their image quality and the way they present, the tips that they can give you, you will just not get. They've trained me, so I've been very lucky to learn from them. I'm gonna start by basically sharing my presentation, which should be about 45 minutes today. Go back to Zoom. Screen 2. Full screen. So can you see the slides?
Yes.
Okay,
Yes.
brilliant. So just as we do, we always do a revision of the last session. So we're just going to talk a little bit about the nomenclature. So I spoke to you about the fact that we're going to use standardized terminology, and the only non-standardized terminology that I want you to think about is the AB profile. Now, we use a terminology that basically talks about profiles. A profile, normal well-aerated lung. B profile, spectrum, which varies from more than 3 B lines per intercostal space to AIS, white lung, to compact B lines. Then you have C profile, which is consolidation or atelectasis profile. A/B profile is a profile that's been described by Daniel Lichtenstein, which basically indicates that you've got one lung which shows aeration and one lung that shows a B or a C profile. And really, that generally means that you've got a focal or an occult pneumonia in that particular region. We see it in babies, but we don't quite call it AB profile. We tend to call it C profile or a B profile without sliding. So we don't use the terminology A/B. But what we will be using is AB profile, which means that you've got A and B profiles side by side, transitioning, where a B profile is transitioning to an A profile where the lung is more aerated. And we'll talk about lung aeration today. We then have A dash profile. So when you have a dash, it means no sliding. A dash profile is an A profile. So horizontal reverberation artifact, no sliding, suggestive of a pneumothorax. And a B dash profile, again, is kind of B profile that you see often with no sliding, really reflective of the fact that you've got a lot of interstitial edema to the point where there's so much fluid in the lungs that's actually affected the ability of the pleura to slide well because there's a lack of lung aeration. The alveoli are also full of fluid. So we basically use this, and this is classical A profile. So you can see sliding on the right-hand side over here at the top. Nice sliding over there, A profile as you go in. Now, I told you that as ultrasound waves go in, they interact with alveolar tissue. The pleural artifact basically may go down. The more the aeration, the better the pleural artifact. The more superficial the chest, the better the pleural artifact. This is an adult scan. Massive amounts of kind of chest wall tissue to go through. In terms of aeration, the lungs a little bit further away as compared, but in a neonate classical, you've got lots of air very close by. Classical bamboo sign that's seen. And when you do an M mode, you get a seashore sign. So really, what is the seashore sign reflective of? That's basically the waves at the top. This is the shore, and this is the sand. And you're kind of basking over here. You're looking at the sun setting in the background. That's a seashore sign for you. Now I'm going to run into trouble. I want to go back to pen. Yeah, okay. So this is basically, again, a B profile. So you can suddenly see that the A profile in between, you've got, when I use the Plura ABCD protocol, I've got ribs, batwing sign, pleura that I'm seeing here. Looks pretty thick actually in this situation. It's continuous, regular, bright. I can see B lines, and really in this region, I can see less than 3 B lines per intercostal space, but I can see more B lines, more than 3 B lines per intercostal space. So actually, I've got a B profile with an A profile. This is what we classically call AB profile. So there's aerated lung with a B profile. So this is the spectrum of B profile that we talked about. So here you've got all A lines, maybe the odd one B line on the right-hand side. So less than 3 B lines per intercostal space. This is an A profile. And then you get more than 3 B lines per intercostal space. So this is B profile. More interstitial fluids means they merge together and you get what I call these rectangles that you see, compact B lines. Just another example of compact B lines over here. So no aeration at all. Then you get what we call this is where you get complete white lungs. Here you can still see the kind of rectangles, but these rectangles have merged into one large area. Now, just remember, AIS is called alveolar interstitial syndrome. What it means is that you've got B profile in more than 3 intercostal spaces on the right and left side. So multiple big areas of the lung. So if you have an A profile here with just this B profile, then these are compact B lines. But if you've got AIS, it's multiple intercostal spaces with B lines. Now, if it's the whole lung, you can see an AIS-like picture in the whole lung, it's white lung. And then white lung has different profiles. So these are just different profiles of white lung. This is proper RDS. So in the middle, what you've got is irregular thick pleura, and you can see these subpleural consolidations come in expiration. They extend right here. Here you've got really thin linear pleura, less kind of thick than here, with no subpleural consolidations. It's all just coalesced B lines. So TTN kind of lung looks like this. RDS tends to look like this. RDS always has subalveolar consolidations in the early phase before surfactant, and that is pathognomonic on it. So this is the AB profile, A with B profile. We've spoken about this. This is the C profile. So C profile is consolidation. You can have static air bronchograms, which appear and disappear, star in the sky appearance. They twinkle. They do not move in and out like a caterpillar. So again, this is just a right upper lobe collapse consolidation is atelectasis. So you can see an A profile on the right-hand side, and then you can see a large C profile. There's so much atelectasis that you can't have aeration. So air is not coming in. If there's no aeration, you're going to get no A lines. And it looks very tissue-like. But more importantly, because there's no aeration, the pleural line is not established. So normal pleural line would be visible over here. But it's not established because you've got complete atelectasis in this region. So really, from our perspective, this is classically what we call a C profile. A-dash profile, pneumothorax, self-explanatory, no sliding. You've got truck sign, mirror image ribs. Now, you saw mirror image ribs today in Heba's slides. You will get it if the lung is aerated. But if it looks so bright that you look at a rib above and it looks like the rib below, I mean, it's just like looking at a mirror and looking at ribs. They're so bright. This happens when there's air in the pleural interface between the parietal and visceral pleura, complete reflection of the ultrasound waves back. This is truck sign. And if you have a barcode with it like this, and you can see the lung point, you know, pneumothorax until test otherwise proven. So why do we get a barcode sign versus a seashore sign? So just remember that normal lung, the pleura slides side to side. So because it slides side to side, the reverberation artifacts of the pleura sliding create sound waves that go down. That basically obliterates completely the no motion that you see. There is positive motion of this pleural line that's translated at the base, and it manifests as sand, kind of a fluffy kind of an appearance. So a seashore sign is a good marker of pleural sliding. If you're confused, put your M mode on and check it, and you'll be able to see a seashore sign. No lung motion means that the no motion chest wall, there's no pleural sliding. So because there's no pleural sliding, because there's air between the visceral and parietal pleura, you're not going to have the motion of the pleura translated down. So you're going to have this kind of barcode kind of sign which reflects no motion from the top to the bottom. That's classically your barcode sign. At the interface between lung sliding and no lung sliding, you'll see a transition of the barcode sign to a seashore sign. And that is your lung point. And what it basically reflects is it defines the amount of air in the chest. Air rises anterolaterally. As you move from anterior to lateral in a supine baby, your air will basically accumulate anterolaterally. It's, if it's a massive pneumothorax, you start going into the posterior axillary line. We've got a baby like that on the unit at the moment. And I mean, it is, you can see massive pneumothoraces. And, when we start desaturating, it's easier and quicker for me to make a diagnosis by lung ultrasound because actually the baby's so edematous, the transillumination does not help. And it takes, time for the radiographer to come and do an X-ray. It also means I have to lift the baby up, put a plate underneath him, the handling, it's quite challenging. So a lung ultrasound over here helps me make a rapid diagnosis. Yesterday it was so bad I had the machine just next to him. So, no, it's a no-brainer using lung ultrasound to try and make a diagnosis. This is what it looks like when you see a pneumothorax, classical barcode sign. So there's no pleural sliding that you see in this region here. You can see movements. You can see breathing movements. Now, this is an adult, so he's breathing very slowly. But you cannot see sliding here. Because there's no sliding, you get a classical barcode sign. B-dash profile we spoke about, I'm not going to repeat it. Now, I'm just going to talk very quickly about lung aeration before we go into our workshop today. Now, just remember, the lungs in the mother's womb, they have no air. So if they have no air, then really no air is like this, classical. So you've got no air here. Really frustrating when the pen doesn't work. Sorry. So you have no air over here. And you've got a B profile coming in over here. So this alveolar interstitial edema. Now, in the mother's womb, this is the way the lung looks. There's no air. You won't even get static air bronchograms because there is no air. There's nowhere that air can actually get in. And that's why this is the way the lung looks. It's very tissue-like. There's no aeration. And as soon as the baby takes its first breath, and if you ever have the opportunity, take a lung ultrasound machine, your probe, your ultrasound machine, go to the delivery suite, take consent from the parents, and you can just leave a probe there as the baby establishes breathing. So you start seeing air coming in, and actually air is going to aerate the alveoli, and you'll start seeing what we call as static air bronchograms. There's just a little bit of pleural line that's starting to be established. You then start seeing established pleural line with a B profile. Just remember the alveoli are still aerating themselves and the interstitial space is full of fluid. So the interstitial space takes dominant and you kind of see a B profile. And then you transition to this AB profile where you have aerated lung. Now the alveolar air is taking dominance. You're starting to see horizontal reverberation artifact. And eventually you transition into lung that we can completely see. Now this is really, really important. This is not abnormal. And you have to be really careful when you're thinking about a baby, because actually you might find that you have a baby who's got no respiratory distress and you decide that you want to do a lung ultrasound. Now, I'm really asking you that if there's no indication for the lung ultrasound, why you're doing it. But if you do it in the first hour of life and you see this pattern, it doesn't mean the baby has an infection. It does not mean that the baby necessarily has, lung pathology. This could just be transitional lung disease. Now, if the baby has respiratory distress, it's a no-brainer. This could be infection. This could be transitioning lung disease. And clinically, from our perspective, we would have to make a clinical decision about whether we decide to treat this baby with antibiotics or not. Now, if you have risk factors and a baby does not have respiratory distress, you're going to use your departmental protocol to kind of screen and start antibiotics. But the diagnosis of transitional lung or lung transition at birth is not made by one scan. You have to rescan the baby, maybe more than a few times. And a simple example that I'm going to give you is that I had a baby who came to us who was in 45% oxygen. This baby had significant work of breathing and basically had a lung appearance, especially at the back, like this. So this lung appearance was what I saw at the back. Thick pleura, an element of kind of severe B profile. Looks a little bit tissue-like actually. And this is a baby 45 minutes old with significant respiratory distress. He's in 45%. He's got a high CO2. Do you want to give him surfactant? Anybody want to give him surfactant? So gestation of the baby was 34 weeks. CO2 of 50, pH 7.27. Do you want to give him surfactant?
FI2 requirement, Doctor?
45%.
Yes, we will give.
Okay, that's fair. I respect that. You could give him surfactant. Anybody else?
You could wait and watch and repeat the scan.
So that is one of the benefits of being able to do lung ultrasound. And a chest X-ray might not show immediate changes. You might get that interstitial kind of pattern. You might get a ground glass pattern. Just remember, a 34-weeker could have TTN and could have RDS. So fluid in the fissure does not exclude RDS in these kind of babies. So I repeated the ultrasound by putting the baby prone and putting the baby on Diopap. So I went on pressures basically from 7 to putting him on 15/7 Diopap. And I just did the X-ray in 45 minutes, and this was converted into this. Now, RDS is not going to behave like that. With RDS, you're not going to suddenly get aeration. You'll get patchy aeration. With time, if you repeat ultrasounds and you're not giving surfactant, you'll start seeing subpleural consolidations. So the concept that I'm trying to teach you today, and that is so important, is that you have to, in the early phases of any evaluation by lung ultrasound, factor in that there is an element of lung transition that's going to take place. And that transition can be impacted by the interventions that you make in terms of your ventilation kind of strategies and approach. So rather than saying that I've done one ultrasound at 1 hour of age and it looks like this, so I'm going to give him surfactant, a serial ultrasound done, which is non-invasive, that can be repeated over 90 seconds to 2 minutes, will give you good information to be able to make your decision. Now, in this baby, we did not give the baby surfactant, even though this baby was in about 40% oxygen for the first few hours of age. At 24 hours, this baby was in air. We transitioned him to Optiflow. By 30 hours of age, the baby had come off Optiflow, 36 hours. So we avoided giving surfactant. It's very expensive in countries like India. Can you imagine the parents having to pay for it? And for a 34-week baby who's about 2.5 kilos, it's going to be a huge amount of Curacif that you're going to give. So it's very costly. Now, using this approach and using the concept of serial lung ultrasound scoring, Jing Liu in China, where he works, which is in Shanghai, in the Shanghai group, in their hospital, have reduced surfactant use in babies over 32 weeks, in between 36 weeks of gestation by 70%. Massive cost saving for the institution. So, it's helpful, and there's good evidence that quality improvement can actually benefit. So now what we're going to do is we're coming into the workshop phase, and I am going to pick on two of you. So who am I going to pick on today? Sevinj, are you able to participate?
Yes.
Beautiful. So Sevinj will give you some help. So what we're going to do is we will let the lovely Dr. Varun, Dr. Varun will help you. So Varun and Sevinj, can you just unmute yourselves? Brilliant. Okay, so I'm just going to give you some history. So just a little bit of method to my madness. I'm showing you scans of the same baby, and I've done them with kind of different frequencies, different probes. Now, this is a baby who was delivered by elective cesarean at 37 weeks, came in, had mild respiratory distress, was screened, started on antibiotics. Initial CRP was 6, white cell count was normal. And this is a scan which is basically at 2 hours of age. Okay, so Sevinj, talk to me. I'm just showing you the left. The right side also showed the same appearance. So talk to me about the scan.
I see A lines. I think that it's A profile.
Okay, so
the first
Sevinj,
one.
We're going to use the Plura ABCD protocol. So how many ribs and intercostal spaces?
I see 1, 2, 3, 4, I think.
Brilliant, absolutely right. And intercostal spaces?
1, 2, 3, 3 or 4.
Four. You can see about 4.
Yes.
Yeah. Okay. So
yes.
what about the Plura? What do you think about the Plura?
Plura is I see sliding. It's not thickened.
Okay. Brilliant.
Yes.
Yeah.
And also I see A lines.
Lovely. Lovely.
And some B line from the right side. One.
Absolutely beautiful. So profile.
A profile. It's
A profile.
profile.
Yep.
Yes.
Maybe with a little bit of B coming in the right. Not a real clear-cut AB where you've got A and B side by side. Dominantly A. And it's the left region. This is the profile that you see in every region on the right side. And this is the back. Okay. Would you like to describe the back?
Back is also 1, 2, 3, 4. 4 costa. No. 5 costa. 1, 2, 3, 4. 4 intercostal space. Also, I see line sliding, but
Brilliant.
Yes, line sliding and L lines, and but its motion is not as in first video, is not active as in first video.
Very good. So good. Sevinj, that's brilliant. Varun, talk to me about L34.
Yes, sir. So in L34, we can, the images are not very clear as we see in the previous slides, but we can see the like at least 3 to 4 intercostal spaces.
Yeah.
And like in the upper part of the image, we can see like A profile.
Yep.
With like bamboo-like appearance.
Yep.
And in the lower part, we are having like tissue image.
Yep.
I'm not sure if it is stomach and the spleen coming.
Brilliant. So you're right. So this is basically the spleen, and this is the stomach, and he's got some milk in his tummy. Yeah. So brilliant. Okay. So A profile, maybe a little bit of B everywhere. So in terms of kind of, if you saw this profile everywhere, what about this, Varun? What are you seeing here on the M mode?
M mode basically say A profile only and with the
Seashore sign.
seashore appearance, yeah, seashore
Okay.
sign.
So the baby has, so just to give you an idea, this is the first image that we did, and the anterior images I took before the posterior image. I put the baby prone, and then I waited for about 60 minutes before I did the L5-6. By that time, this baby's respiratory distress is less. So can you see the difference between the respiratory rate between L3 and L4 and L5-6? So you can see the baby's clinically getting better. He's got an A profile anteriorly and posteriorly, and you've got aerated lung everywhere. So what is your diagnosis?
TTNB then.
Yeah, it could be normal lung transition with transient tachypnea of newborn. Now, just a few things that I want to kind of highlight to you about this, and we'll have a look at the X-ray, is I'm using different frequencies here to kind of give you a feel of what is a good quality image and what is not such a good quality image. So when you look at L34, this is a good quality image. I've got the batwing sign. I am perpendicular. And because I'm perpendicular, I have good delineation and anatomy. I can see the pleura. It does not appear as thick as I would like it to appear. I've got good bamboo sign with A lines right to the bottom. So I've got good depth and good penetration up to 4 centimeters. And really, from my perspective, I'm also able to delineate a B profile. Now here, what has happened is I've just changed the frequency and I've gone from a frequency. So here I'm using 8 and I've just increased the frequency here to about 10. And what you can see by, increasing the frequency, the images become a little bit more granular. It's more defined. The pleura, again, just looks slightly thicker over here. It doesn't affect my interpretation. But really, what it's doing is basically giving me a little bit more delineation of the superficial regions as opposed to the kind of deeper regions if I start using a higher frequency. And here, I've put the frequency up to 12, and I basically lost out on the deeper regions. So there's benefit in being able to kind of adjust your frequency. If you can't adjust frequency, then you can adjust your depth. And I don't have a problem with you adjusting depth in situations like this. It'll give you a much better image, and it's not going to really compromise what you see at the bottom of the image. So just a flavor of, how you can image optimize using your frequency. The other thing I would say is that I'm using what we call is, sorry, I'm just going to rub everything out because it screws my presentation up. So this is the image that you see here is sharp mode. Please avoid using sharp mode. I would use soft mode. So when you use sharp mode, and you can see it's very tissue-like over here using sharp mode. Sharp mode is we tend to use it to kind of delineate tissue consistency. Actually, you're not doing that because this is all artifact. There's no tissue here. The tissue is all above the level of the pleural line. So you're seeing a seashore sign, but really what you want to do is keep the soft mode turned on where possible. If you can't do it, don't worry. You're still getting good kind of delineation on it. If you have pleural sliding with this kind of an appearance everywhere, it's normal lung. Okay. Again, this is just another example of the same baby, and this is R1, R2. And this is where I'm saying you're using sharp mode versus soft mode. And you can see the difference. Just, it doesn't make too much of a difference, but really, personally, I would say that the risk of using sharp mode is you're turning the harmonics on. And if the harmonics are turned on, as they are on the right-hand side over here, then what is going to happen is you will attenuate B lines because with the harmonics turned on, you tend to attenuate B lines and artifact. So it's just making sure that your harmonics are not on if your machine uses harmonics. It's the same R1, R2 kind of, this is the R3, R4 profile in the same baby, and you can see the slight difference in images when you use them. Again, L1, L2, it's an A profile. You've got seashores This is the X-ray. Looks okay. You know, transition.
Dr. Alok, one
Yeah.
question regarding this soft mode and sharp mode.
Yeah.
Like how we are able to like on it and switch it off.
Your machine will, if you're using a Philips or a GE, it will have buttons for soft and sharp. I'll take a video of it and send it so that people can understand. It may be that you don't have it on your machine and your machine defaults to the settings and you can't change them. Just remember, you have to make an interpretation of this image after clinical correlation. So if I see this image on R3, R4, and my baby, kind of, and this is the image that I see in every area of the lung, and my baby is tachypneic with a pre and post ductal saturation difference, then I'm really thinking about whether he has pulmonary hypertension, and I might do an echo. So clinical correlation becomes key. In making a kind of a diagnosis, this is also an A profile, this is also an A profile. So it doesn't make a big difference. Any questions? Well done, Sevinj and Varun. Very good. Okay. Who wants to go for the second case?
I will
Anybody?
go. If you don't mind.
Nisreen, yeah, sure. Nisreen is ever the so we'll give you help, Nisreen. So Nisreen, Dr. Dias, are you able to unmute yourself? Dr. Dias might not be able to. Liz, Dr. Collins, are you able to unmute yourself?
Yeah.
Okay, brilliant. So we've got Liz and we've got Dr. Nasreen. So this is a baby. It's an infant of a diabetic mother. It's macrosomic and it was 4.5 kilos. The mother went into labor and it's a breech. I think the overall kind of feeling was it's best that we do cesarean. The baby, steroids are no longer given at that gestation. So the mother went for an elective cesarean for the baby being breech. And this is really an X-ray, a lung ultrasound done at 60 minutes. So Nasreen, talk me through this. So you're going to interpret R1, R2.
Yeah, now we will start by R1. We can see butt-wing sign. I'm seeing around 3 to 4 reps.
Yep.
And yes, and yeah, there is also mirror of reps. I see, any little.
Yeah, it's mild. It's not like you can see the rib.
Not like
Pneumothorax.
Not like pneumothorax, and there is the like thickening in the pleura, but maybe acceptable around يعني higher side, يعني around 1 millimeter for term baby. It's okay.
So we'll talk about that. That's brilliant. Okay. Yep.
Yes, and now we will go to A line and B line.
Yep.
I can see maybe two A line. It's not so much clear. I can see B line more, يعني.
Brilliant. Especially in expiration. It looks as if there are more than 3 B lines in the middle.
Yeah.
So, Dr. Collins, I'm showing you R1, R2 on the left and R1, R2 on the right. What is the difference between the two images?
In the other side, there is more A line, يعني A line more clear.
Sure, Nasreen, I was just, yeah, you're
Okay,
right.
I think it's on the L2 more B lines, minimum
Okay.
A lines for me.
Okay, so just comparing these two images.
Different penetration. Frequency different.
Yeah, brilliant. Just so frustrating.
R1, there is a high frequency.
So these are the two images we're comparing. They're both R1, R2, same baby. So am I using a high frequency or low frequency over here?
High.
Yes, you're right. I'm using, and I've image optimized. So I was using a frequency over here of about 12. Naturally, because it gives you a better superficial image, there's more focus on the pleura, and you can see the B lines originating very nicely. This kind of B line that you see coming here. Can you see how much better it looks superficially? But actually, once you drop the frequency, you get better depth, and you can see how what the pleura looks, a little bit less well defined over here. So really, from our perspective, it's just giving you an example of different frequencies and how you adjust. One is giving you slightly better depth and deeper kind of views of the A lines, and the other one's giving you a much better kind of delineation of the fact, even the mirror image ribs, they're so much better seen when you use a kind of a higher frequency. So my my reason for showing you this is just to kind of give you a feel of don't hesitate to play with your probes to try and make an interpretation. And clearly, you know, uh, what you're seeing over here is, would you call this an A profile or a B profile, Nasreen? Hand on heart.
Here it's يعني in the clear side, it's a profile more.
Yeah. Okay. What about R34?
Down R3. I can see like different area A and B. يعني in the right side there is multiple A, and in the other side B more. يعني it's A B profile, and
Well
there is
done.
a slide.
Okay. Okay. So you're right, and that's the wrong answer. Okay. So what I want everybody to keep practicing is, can you see the bat wing? How many ribs?
1, 2, 3, 4, 4.
Yep. And how many intercostal spaces?
1, 2, 4 also.
Yep. Okay. And what's the pleura? Is it thin, regular, continuous?
It's not continuous, right? There is broken.
So no, so just that's really good point when you're using the pleura ABCD protocol. So just remember, pleura is broken if it's broken in between. Here it's broken because of the rib shadows, but it's continuous. It's nice and thin and delineated over here, and then it just becomes a little bit less well delineated over here. But it's still pretty sharp, and there are no subpleural consolidations. So A and B. So you've got transitioning area, lung sparing. What do we call the sign, Dr. Collins? So, Dr.
Double
Collins?
point?
Yeah. So it's a double lung point. So Dr. Collins is not getting a chance.
So I'm too slow. I'm up tonight.
Okay, God bless you. Okay. So what about R56? So Nasreen, we'll let Dr. Collins talk to us about R56.
Okay.
So the R6, it's top, yes?
Yeah. It's the back, R56.
Yeah. I mean the top film on
Yeah. No, this is R56. It's the bottom. So I'll just show.
okay. Okay. So I can see 4 ribs and 3 intercostal space.
Yeah.
And backwind signs, but the pleura also, I would say that irregular, probably slightly
Well
on
done. Well done. I would agree, actually. So
but I can see these dots. I'm from Fon as well, but on a
so you see those areas there.
this one and on through the other one. So yeah, on the top,
Yep.
like 2 dots.
So it's an A or a B profile?
Yeah. I think it would be probably B profile more.
Brilliant.
Because more B lines and I think only 2 A lines.
Yep, you're absolutely right. So you've got, sorry, I've just gone to the next slide. And if I can turn this off, it would be really helpful. Sorry. So you've got a B profile. So you've kind of got, just remember, right lung, A profile, well aerated. Right lower, AB profile with a double lung point. So some lung sparing, normal aerated. And as you go to the back, this is a supine baby. You get a dominant B profile, a lot of interstitial fluid. No subpleural consolidations, but you're just starting to see a little bit of atelectasis because the back's not well recruited. You're losing your pleural line here in expiration. The pleural line is visible here. So it becomes a little bit discontinuous because of this atelectasis. So it's a transitioning lung. Okay. Let's look at the left.
Can I ask a question?
Yeah, go for it, Hafiz. Yeah.
Previous slide.
Yeah, I'll just go back. Yeah.
The R1, R2 image on the right, the image optimized.
Yeah.
Towards the apex of the lung.
Yeah.
You cannot see the pleura and there's some tissue like
Thymus.
It's thymus.
It's thymus. So that is thymus with a capsule. How do I know it's thymus and it's not a right upper lobe consolidation? Is I can see these large vessels. I'm just trying to play it so that so can you see you don't have any static air bronchograms in it, and you can see these large vessels inside. So that is thymus, and this is the thymic capsule. So it's not a right upper lobe consolidation.
Thank you.
Yeah, no problems.
Dr. Alok, may I ask one query?
G.
How do we know which is inspiration and expiration?
So aeration of the lung and appearance of A lines will only be an inspiration. Do you get what I'm saying? So if you see, so just an example that I'll give you, if you focus on this area here, can you see? So inspiration, the A line is coming in, and this B line will be expiration, because that's when alveoli will collapse and interstitial fluid will be able to overcome. You get what I'm saying? So with experience, with time, so a static air bronchogram, you see air trapped in an alveoli when air enters. So it has to be during inspiration. So what I would say is that if you see air kind of A profile coming in to a place where you have kind of other artifacts, that would be inspiration. And it'll be easier for me to explain when I show you atelectasis. Does that make sense?
Yeah. Does the movement of the pleura or the direction help us to know?
Yeah. So if the pleura, so it disappears. So can you see how in inspiration, the pleura here appears? Can you see? It appears. It's sliding in and out. So
Yes.
expiration, it's collapsing. So when it disappears, that's expiration.
Right. Thank you, sir.
It'll become much more apparent soon. Okay, so this is the left side. So what do we see on the left side?
Here, A profile also.
Yeah. A profile, left upper. So it was the wrong answer, Nasreen. Now the right answer. Now talk to me about this.
Which one?
So L12.
Ah, you mean no sliding here?
What do you think? Yeah.
Can you do video, please? So it.
Okay. Can you see it now? I'm just going to play it. Keep playing it.
No sliding, right?
Okay. So brilliant. But my advice is stick to the protocol. So can you see ribs?
Yes.
So you can see the batwing sign. So I can see 1, 2, 3, 4 ribs. Okay.
Yes.
And my worry is that this rib, it's very mirror image like.
Yes.
Yeah. So actually, I'm really concerned. I'm not convinced I can see sliding over here. And I've got an A profile underneath. Can you see? To the point where I can see mirror image artifact of the ribs all the way down. You know, this artifact, can you see here, 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 here? So very worrying. Okay, now let's look at the M mode. Look at the M mode. Now, this is something I want you to keep practicing, M mode clips. So when you put the M mode there, it just is so easy to see whether the lung is sliding or not. So this is R12. Can you see sliding in R12?
Yes.
Yeah.
Okay. And this is L12. Sliding? No sliding.
No. No
Okay.
sliding.
And this is the barcode and this is the seashore. Can you see how different it is?
Yes.
Yeah.
Okay, so we're a little bit worried about potential that there's a pneumothorax L12. And when you go to L34, which is the lateral region, what do we see? So, yep.
And no sliding. Can you make it video again? Like atelectasis, right?
Brilliant. So, okay, wrong answer. Please keep to the protocol, Nasreen. So how many ribs?
1, 2, 3.
Okay, rib shadow. Okay, can you see
Yes.
pleura?
No.
No.
Brilliant. No pleura. Okay, now you have no pleura in this region. And
So
what
it's
kind of
pneumothorax, yes. It's good.
no,
No?
Air bronchogram.
so I can't see many air bronchograms. It's atelectasis. Maybe some static air bronchograms I can see over here, more
Yes.
over here. Now, if you have sliding, can you have a pneumothorax?
No.
Okay.
Yeah, if you've got slide, then you don't have pneumothorax.
Okay, so you have sliding over here, so you can't have a
Yeah.
pneumothorax. So the pneumothorax extends only in the L1-2 region anteriorly. When you go to L3-4, you get a B profile, okay, with some atelectasis, no pleural line. So potentially lung that might be recruitable. Okay, what about L5-6? What do we think? Sarvesh, you have something to say? Go for it.
So we can see 5 intercostal space.
Brilliant.
Pleura is well defined with sliding.
Yeah.
And mostly it is B profile.
Okay, excellent. So technically, from our perspective, having seen this, you look at the right lung, and you've kind of got transitioning lung with an A profile with sliding everywhere. Okay. But in the left lung anteriorly, you've got the suspicious area over here with more of a B profile and some atelectasis. Okay. So right lung better, left lung better. Which is more aerated? Sarvesh.
Right.
Okay, right is more aerated. When you look at the left upper, possible pneumothorax, anterior. Okay. But lateral B profile, left definitely with a B profile. Maybe a little bit of atelectasis on the left lateral region. So let's look at the chest X-ray. This is the left, the chest X-ray. So what you can see is, even with this, there's basically what you call as transitioning lung with fluid in the fissure, but you've got an anterior air leak. And really, when you move into the lateral region, you can see the lung atelectasis because of compression from the air leak in the R3-4 region. That's what you're saying, the atelectatic lung. But when you move posteriorly, there's no air. So there's no lung atelectasis, but it's still transitioning lung. And we know that the left lung tends to transition later than the right lung. So it's less well aerated. It's just interesting how, when you look at these kind of profiles, they give you so much information. My advice is stick to always, as much as you have the urge to say, this is an A profile, this is atelectasis, do the sequential segmental analysis of the Pleura ABCD protocol. Okay. Last one. So, Manju, are you able to unmute yourself?
Yes, sir.
Okay. And Dr. Reddy, are you able to unmute yourself? Pranita? Maybe not. Maybe Dr. Reddy can't. Dr. Ruby, are you able to unmute yourself? Possibly not.
Yes, I can.
Okay,
Yeah.
you can. Okay, so I'm going to ask Manju first. So Manju, I'm not giving you any history. Okay, this is what you can see. So talk to me about this R12.
Okay. We can see around 1, 2, 3 intercostal spaces.
Brilliant.
And there is, I think, if there is no sliding of pleura, it is very sluggish movements of chest. I think pleura is not sliding,
Hmm.
and there is A profile
Hmm.
along with towards left it is B.
So you're seeing this is an extended view of R1, R2 in a baby. That's liver, to reassure you. That's liver.
Okay.
Okay. So clearly you're a little bit worried about sliding, aren't you? Is there sliding? No sliding. What do we think, Dr. Ruby?
It's hard to say.
Mm.
Maybe it's a breathing movement because I see the barcode sign in the next one.
You sure it's a barcode sign?
It looks like a barcode sign.
Okay, this is a barcode sign. Does it look like a barcode sign?
On the left.
So
On the right side, on the right, the third image, it's a seashore sign.
Okay, so
But this one I'm a little confused.
This is a barcode sign, okay? Okay. Does this look like a barcode?
So the extreme right, the third one, that doesn't look like barcode. But the middle, I'm not sure. It looks like I don't know. I think there is some breathing movement. It's hard to know exactly, but definitely I can see the liver.
Okay, brilliant. It's a tough one. It's a really tough one. Okay, so this is a baby who's oscillated. So does that help? So he's oscillated. So
Oh, yes. So if the baby is oscillated, so probably what we are seeing, I think, is the oscillation, and it would be, I think, because we won't be able, I'm not sure the baby is really breathing because maybe baby is paralyzed or something.
Brilliant.
So so even if there is a no pneumothorax, I think it would be hard to see the pleural movement.
Okay, so what can we see here? So I'm confused in oscillation whether there's sliding or not and whether there's a pneumothorax. So the question from my perspective is, if I'm worried about it, is it safe for me to put him on conventional just to see whether he's got sliding or not? And that's what I've done over here. So can you see the difference? There's a comet tail. Can you see the comet tail there?
Yes.
So if you have a comet tail, can there be a pneumothorax?
No.
Okay. For the experienced eye, this is a seashore sign on oscillation. It's not easy. I agree. And it's easier if you had a barcode sign next to the seashore sign for you to compare. This is classical barcode. So I agree, it's not easy. So just remember, clinical correlation is quite key. And I mean, the one thing is I can see comet tails over here. But if there's any confusion, what am I going to do?
Change the mode of infection.
Sorry?
Just X-ray?
Yeah, brilliant. So what I'd say to you is, it's not a matter of being brave and excessively overconfident. I think if there's any confusion and the baby is stable, enough to kind of warrant it. He's not crashing and burning. He's not transforming like a light bulb on that side. Get a chest X-ray if you're worried. But yeah, this is sliding. And an experienced eye would say this is sliding. There's no truck sign either. There's no mirror image reverberation artifact of the ribs visible all the way through. So it's just an example. Is there a problem here? Anybody? Anybody in this group? I will post to you whatever you want. So for the colleagues in UK, I will give you a bottle of champagne. For the colleagues in the UAE, you can have dates, good, high quality, lovely dates. But tell me, what's the problem with this R1, R2 image? Quality assure it. Anybody? Okay.
Problem mean technical, Dr. Alok? You mean something technical or like an abnormality detected, like
So
a finding?
no abnormality detected. We've discussed all the abnormalities. Are we okay? Nobody gets the prize, but are we happy that we've covered the
How
whole
are we obtaining images while on oscillator?
We can do it. You just the way you would do normally. So you would put your probe perpendicular and you would get it. So the point I'm trying to make is you're getting the majority of the liver here. You're getting a lot of R2. Are you getting all of R1? Can you see you're not getting anything at the top? I mean, you should be seeing thymus. You're not seeing thymus. So just be very careful. This is labeled R1, R2, but you're not getting all of it. Now, I just want to show you R1, 2. Now, can you see R1? And what can you see?
Yes, C profile here.
C profile.
Okay, so this is thymus. This is C profile. Okay, these are static air bronchograms. They're not even disappearing, and there is no pleura. And this is what we were kind of getting, the A profile. C profile, C profile. Okay, R3-4, as we move down, you get a little bit laterally. This is actually R3-4. I've mislabeled it. Kind of, what is this? This is B profile, pleura. You're getting the heart in the way, simply from my perspective. And why are we getting heart in the way?
This is the right lung?
Yeah.
Maybe I'm tilting the probe a little bit, so getting from the left side the heart.
So what happens when you get quite a large area of atelectasis?
You mean dextrocardia or something?
The heart.
Okay, shift.
Shift.
Yeah. So the heart gets pulled towards the collapse consolidation. So that is why the heart is starting to come in the R3-4. This is R3-4. So basically you have quite a large area of atelectasis. So tissue sign, static air bronchograms. So this is technically what the right lung looks like. We've been looking at the right lung, aerated at the bottom, but with the right upper lobe collapse consolidation. I haven't shown you the left side here. So again, the main issue here is where's the tube? So what you want to do is pull the tube back and then repeat this lung ultrasound in about 60 minutes. So what we've seen is, if I summarize, we've seen A profile, we have seen B profile, AB profile. So B profile, AB profile. We've seen A dash profile in clinical cases. We've seen B profile with atelectasis. And then we have seen C profile with a large area of right upper lobe collapse consolidation. So you have seen all the profiles and we have put them into clinical context. You've done beautifully well in your interpretation. And at the same time, in this session, we have learned mental modeling. So if I summarize, you have come to the end of your didactic teaching. We have talked about profiles. We know how to interpret the normal lung, and we know now how to talk about profiles and mentally model to make a diagnosis using sequential segmental analysis of the pleura ABCD protocol. Any questions? Any questions? So what we will be doing is we'll be discussing cases. So our sessions now, the expert speaker sessions will start and they'll be in a slightly different way. The expert speakers will usually talk for about 45 minutes. We'll be taking individual pathologies. And then after that, what we will be doing is we'll be doing peer review for the people who can share. And I will be presenting a case every session like this. One case at the end of it. Prizes for the people who do well. You know what the prizes are. At the end of every session, what we'll do is we'll save the session with the peer review in the folder for you to be able to see it if you weren't able to see that session on that particular day. Again, just for those of you who want one-on-one peer reviews, think about how you're going to do it. For those of you who can't do it because of governance, patient identification issues, keep practicing, do it locally. Look for a master trainer, look for somebody who can give you help. I know for my colleagues in Portugal, Sarah Figueirado is their master trainer. You also have Ana Vaz in Portugal. She's fantastic. Both of them are accredited master trainers. I mean, for my colleagues in the UK, Dr. Praveen, Kishore, and Abhijit are on the course. They will be there for peer review again, and very happy to help. So, if you're not scanning now, you're wasting this course. If you haven't put a probe on a baby, and you don't have to do peer review to put a probe on a baby. then really you're missing out. So please, my humble request is try and do that. I'm grateful for your patience. God bless you all. And the next session now will be on Thursday. Thank you.
Thank you so much.
Thank you. Good night.
Thank you.
Thank you.
Doctor.
Yeah, good night, sir. Thank you. Bye.
Thank you.
God bless you, sir. And ma'am.
Thank you, Dr. Alok. Thank you, Dr. Alok.
Thank you, Dr. Ashraf. God bless you. Your session is next. We look forward to it.
Inshallah.
Yeah, I'll send you
Was it
dates.
90
It's
minutes or 90 minutes?
1 sec. I'll just check the date. I
It'll be
just
1.5 hour.
it'll be 1.5 hour. What we expect is about 45 minutes of presentation. So I've got Abhijit presenting for the next session, which is the abnormal lung on the 9th, and you're on the 12th, which is Sunday, which is 90 minutes. Yeah.
Yeah, 90 minutes because I make all course يعني all pathology what you
That's
physics
fine.
and
Okay. So what we might do is we won't do peer review that day. We'll just do a speaker session.
yeah,
So don't
because a
worry.
lot of يعني it is
Yeah,
inshallah
yeah.
it is wonderful presentation inshallah. Thank you.
No, please take your time. No hurry. God bless you.
Thank you.
Okay.
Bye.
Thank you.
Bye.